So, moving on to our next speaker, HPV screening program in Malaysia. And our speaker is, go back to my program. Our speaker is Dr. Zakiah Mohd. And Dr. Zakiah is a public health physician in the Family Health Section, Family Health Division Sector, Ministry of Health. She has authored and co-authored publications regarding cervical cancer and HPV. Welcome, Dr. Zakiah. Use that or laser pointer, or how do you prefer?
All right.
That's forward or back here.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon to every one of you. So first of all, thank you so much to the organizing committee for inviting me to share some of our latest policy in relations with the cervical cancer prevention program in Malaysia. So the topic that was given to me is HPV screening program in Malaysia. So I'm going to talk and relate with the theme of our event today, the impact of quality pathology on the health economy. So basically, this is a content and the flow of my presentation. So as a start, we know that cervical cancer is a preventable disease as it results from the human papillomavirus infection. However, it remains a leading cause of cancer death, especially in the developing countries, because of the high infection rates and also lack of comprehensive care, and also the healthcare system quite weak. And nearly all cervical cancer is attributable to HPV infection. Some study quotes that almost 80 to 90% of the cervical cancer is actually the causative factor is actually HPV infection, especially the high-risk HPV infection. And the nature of this HPV infection is actually through the sexually transmitted. This is actually, HPV is commonly related with a sexually transmitted disease. And this is actually, most sexually active women and men will become infected once in their lifetime. So the nature of this HPV infection, once get infected, it will actually resolve by themselves within 2 months to 2 years, depending on the immunity of the women themselves. And the peak time for infection is actually shortly after becoming sexually active. So this is actually the main focus and the main aim for, especially for the policymakers, to start to think on when to give the HPV vaccination. What is the best time to give the HPV vaccination as a primary prevention for the cervical cancer? And if the HPV infection is repeatedly infected, especially the high risk, and not detected, it will lead to the precancerous lesion, which may progress to invasive cervical cancer. And this is actually a crucial point for the policymaker to start to think on the best options for the screening to improve the detection rate and also to bringing down the incidence of cervical cancer overall. Worldwide have said that more than 200 types of HPV, so it can be categorized into low risk and also high risk, and there are more than 12 genotypes that are causing anogenital cancer, which in this matter, it is related with cervical cancer. There is one study, local study in 2007, to see the economic burden for managing the cervical cancer. It showed that almost $76 million has been investing in managing the cervical cancer. And out of that, only 10% is actually invested in cervical cancer screening. So this is actually another clue for the policymaker to start to think on the effective way to tackle these issues. So this is actually the HPV virus. So in terms of epidemiology of these HPV genotypes in Malaysia, especially for those who have a normal cytology, the prevalence of HPV positive in Malaysia was around 7.2%, and the high-risk prevalence was 6.5%. And out of this, the majority or the highest was is actually coming from the HPV genotypes 16, 52, and also 58. Talking about the cervical cancer in Malaysia, this is actually the third most common cancer among women in Malaysia, and it started to increase at the age of 35, and the peak between the age of 50 to 74, and commonly Chinese had a high incidence rate, and mortality rate in Malaysia due to cervical cancer was noted as 6.3 per 100,000. Apparently, 41% patients presented at late stage, and of course, it will tie with the economic burden to the country, especially in the matters of the treatment and managing the later stage of this disease. And in 2018, WHO has called for action towards achieving the global elimination of cervical cancer. The three main pillars, the prevention pillars. Pillars number one, to ensure this elimination goal to be achieved, we can achieve, the country must make sure that 90% of girls fully vaccinated by the age of 15 years. Second pillar, 70% of women screened using a high-performance test by age 35 and again by the age of 45 years old. In this context, we are referring to HPV testing. And the third one, the 90% of women that need further management get a prompt treatment. So all these pillars is very important towards the elimination goal, which was defined as when a country have an incidence of cervical cancer as less than 4 per 100,000. So this is our journey for cervical cancer prevention in Malaysia. We have started our journey since 1970s, whereby we started to introduce pap smear as part of the maternal and child health program. So at that point of time, we targeted the women aged 20 to 75 years old. We target more on the postnatal mothers and the family planning acceptors. So apart from that, in 2010, so this is actually a very big decision by the government, showing the commitment from the government to address the issues of the cervical cancer prevention. The government has approved and endorsed the HPV vaccination as another what we call policy. It is actually a school-based HPV vaccination, whereby we start to give to all the 13 years girls at the school. And apart from that, another milestone that we are at the moment start to have a so-called quite a stable thing. So in 2019, we are actually in a serious mode of discussing about the possibility of shifting the cytology screening to molecular screening. So apparently in 2023, we managed to transform and also managed to enhance the cervical cancer screening through HPV testing, and this testing are available in all our primary healthcare facilities in Malaysia. And when we are talking about screening, cervical cancer screening in Malaysia, so people, especially at the international level, will always ask Malaysia, especially WHO, WIPRO, and every part of the world. So, what are the screening policy? So, I think that this is actually something that we can share with all the pathologists here. So, at the moment, we have 2 screening methods. One, we still keep cytology, and another one, we are in the midst of shifting towards HPV testing, molecular testing. So in terms of the policy, we keep to screen all the sexually active women aged 30 to 65 years old. So for the first screening method, using the cytology, we screen every 3 years after 2 consecutive years are negative. And if you see, the majority of the contributors or the providers are actually from the government. When we are talking about government, not only KKM or Ministry of Health, but also from the university hospitals, from the Ministry of Family, Women and Ministry of Women Family Development. So these are all the government bodies that are subsidizing and also provide the screening to all women in Malaysia. So the rest, almost around 30%, are actually coming from the NGOs and other private entities. So this is the current HPV testing, one of the screening methods that we are going to emphasize and we are going to enhance further. So again, the target group is almost similar, so 30 to 65 years old. And those below or above this age, we will advise them for cytology. And the interval for this screening is 5 years. So they can be screened every 5 years once the screening are negative. So we emphasize on the self-sampling. So this is based on the evidence, okay? It shows that most of the women in Malaysia have a problem in terms of they are quite shy to go to our healthcare facilities, embarrassed, okay? Feeling discomfort. So all of these gaps, okay, and challenges, we try to initiate to improve the screening techniques by introducing them with the self-sampling. If, let's say, they are not confident and not comfortable with the self-sampling, they can always ask our healthcare providers for assistance. And we'll see that not all women accepting the self-sampling. Most of the women at the remote area are quite reluctant to accept this self-sampling concept. So we assist them in taking the samples. And of course, we are using the molecular platforms, using the PCR base. So this is actually the latest guideline or the latest algorithm in management of HPV result. Initially in 2019, we do the screen and treat approach. But later, when the program started to stabilize and we get all inputs, especially the pathologist inputs and also the gynae oncologist inputs, we shift the approach from screen and treat to screen, triage and treat. Okay, so this is actually the latest guideline in 2023. And this is the Malaysia's experience in transition of the policy from cervical cancer using the cytology to HPV policy. So as I mentioned just now, we have a very serious discussions on the transition back in 2018, where we engaged with all the main stakeholders, especially the academics, to improve or to get the evidence base, because the evidence is very, very important in making sure that the political are quite confident with what we sell to them. So by engaging with, I think, I'm not so sure whether you're all aware or not, the Rose Foundation from PPUM, so they run a feasibility studies on the HPV self-sampling in our primary healthcare facilities. So this these findings is actually part of the documentations and also mandate and evidence to show the justifications on the shifting work, okay? And the shifting work started by phases because of the upfront cost is so costly at that moment, so we decided that we are using the phase by phase in the matter of the transitions of the screening. So the initial phase was in 2019. We established the test in 3 states, but now we have implemented in all over the states, almost 1,200 our primary healthcare facilities in Malaysia. And apart from that, we we must have something like what we call the long-term strategy. So that's why in 2023, we managed to endorse our cervical cancer elimination plan of actions 2021 to 2030. This is actually in relations with the WHO work towards the elimination strategy. And we have a regular meeting, regular engagement with all the main stakeholders, with all the main clinical partners to improve the services, to improve the policy from time to time. So this is some of the findings. We started, as I mentioned, in 2019. So until now, the cervical cancer screening coverage is not so good in Malaysia. However, we have actually some limitations because our cervical cancer screening or whatever screening that we do in Malaysia is more opportunistic based rather than population based. So that's why the coverage is not so good. However, even though this is not so good, but I think that impact is so good. Okay, so as we can see from here, the coverage is varied around 22 to 26%. And if you see that the proportions of HPV testing is actually increased from years to years. Okay. And this is actually the prevalence of HPV positive since HPV testing was carried out in Malaysia. That was 4%, and basically most of the women aged 30 to 49 years old are the one that get infected more as compared to the rest of the other age group. So, what are the role of laboratory services in HPV screening? Okay. Well, I think that HPV screening is tied very tightly with laboratory services. So it involves with sample processing until reporting. And apart from that, the elements of the quality control, the data management, and innovative research do support the public health efforts towards the elimination strategy. In terms of how these things will support, in terms of the highlighting the epidemiological surveillance, okay, highlighting in terms of the policy improvement by having a good research and development, and highlighting the needs for the training, especially to our healthcare providers. And apart from that, it can enhance our screening program because we know that some of the equipment, especially the mobile equipment, is necessary, especially when we are going to enhance our services to the remote area. So I think that is the role of the laboratory services, especially in making sure the HPV screening success in Malaysia. Well, this is actually the impact of the screening. So that's why the theme today is actually quality pathology. So when we're talking about the quality pathology, we know that HPV testing is actually one of the very effective tests. So in terms of the detections of the pre-cancerous lesion is actually quite effective as compared to the cytology, and they are actually validated in a population platform population-based platform. So I think that this is actually, by having HPV testing or HPV screening, it can produce good data, reliable results, and accurate results. This is very important for the specific and effective intervention later, especially management of the precancerous lesion. And apart from that, we are introducing the HPV self-samplings. So the element of PCR base is actually very important to ensure that the test and also the results are very reliable. And apart from that, all the platforms and all the screening tools must be validated with the population, clinically validated population base, and has to follow all the requirements that are needed. And I'm sure that everything is are already known by you all. So this is economic impact. So this is the latest work that we have done in the Ministry of Health to study on the simulation and the timeline for the elimination years. So among the variables that we are capturing are the vaccination rates, the cytology, the transitions of the cytology to HPV testing, and also the coverage. So overall, the conclusions of this finding is shows that 90% HPV vaccination coverage, plus transitioning fully to HPV every 5 years by 2030, plus increasing the screening coverage to 70% by 2040 will lead to an 18 years acceleration in elimination than liquid-based cytology. So this is actually the economic impact in terms of the total screening costs, total tests needed to perform, the elimination year, and cancer cases avoided from 2023 till elimination years. If I may read, the cost minimization was largest when transitioning to HPV testing every 5 years, with coverage retained at 25%. So it is around 340 million cost reduction, followed by HPV testing twice in a lifetime with a coverage increase to 70%, which is 260 million cost reduction. So further cost effectiveness is needed to assess the implications of the HPV testing transition. So this is a very, what we call, very good studies in terms of highlighting the policymakers in the Ministry of Health to start putting on the long-term strategy towards elimination of cervical cancer, plus the cost impact towards this reduction or towards this elimination years. So another impact is actually the workforce productivity. So we know that by having healthy workers, they can produce more. They can give what we call the productivity more to the country. So in terms of the productivity, we measure it into two: the community and also our healthcare providers. So for our healthcare providers, most of our healthcare providers always say that this HPV testing is actually a very, very good test in terms of bringing down the total, what we call the time of dealing with the screening, and basically they can do a lot of things, okay? They can screen other people more, they can do many other works in our clinic. Okay, so by having this HPV self-sampling, meaning to say that it will cause a productivity in terms of our nurses, our doctors tend to see more cases rather than focusing on all the procedures that they need to take using the pap smear. So apart from that, in terms of the population, okay, acceptance. So this is actually a good, test that are acceptable. In terms of the acceptability, are quite high in the population because they feel that this is more like a privacy. This is more simple, not pain, and they are volunteer to do that. Okay. So these are some of the issues and challenges. So of course, number one, our screening approach is actually opportunistic rather than we aim for the population base. Like in Australia, they are more like a population base. Population base meaning to say that we need actually to have a cancer registry. So in terms of having this cancer registry, we need actually to have more funding. Okay. So number two, in terms of the accessibility and healthcare systems, even though we keep mentioning that our healthcare services in Malaysia is majority subsidized by the government. However, there are out of pockets, and this is actually not applicable to all the population. Okay, all the women in Malaysia. Number three is in terms of the continuity of care. So it's very sad to see that some of the tests, okay, the loss to follow up is quite very challenging because some of them are quite reluctant in terms of the continuations of the follow-up in the hospital for further management. And apart from that, availability of the infrastructure and technology, especially on the advanced lab facilities and diagnostic equipment, this is actually tied with the funding issues as well. So of course, insufficient public fundings and inadequate public-private partnerships. So the way forward, we need to transform the screening policy from cytology to primary HPV testing by phases. So that's why the study and the simulation study just now is very important for the policymaker to start to think on the proportions, the planning for the mid-term and also the long-term. And number two, we need to build a strong alliances with key stakeholders in enhancing access to HPV testing. So meaning to say that we need to collaborate and do a more effective partnership with other agencies like the other agencies that also are doing these HPV screening or cervical cancer screening. Number three, we need to increase the promotional activities to increase the screening uptake. And number four, we need to strengthen the real public-private partnership. And finally, we need to strengthen the monitoring, evaluation, and research to improve the services. And I think these are all my reference. So with that, I'll thank you.
Thank you very much. We are trying to catch up a little bit of time, but we've got two quick questions. If someone's already had the vaccine, HPV vaccine, is there any chance of being infected? To be infected after vaccination? If you've already had the vaccine, would you have, what's the chance of being infected by HPV?
So this question is, if you have the vaccine, is there a possibility for you to get infected? The answer is yes. So that's why the importance of the screening, when you reach the age of screening, because the vaccine is actually covering to those meaning to say that to those types of vaccines only, like Gardasil 4, like Cervarix or G9. So that's the message that we need to emphasize to those population that have been screened and that have been vaccinated, that the potential of being being infected with other types of HPV is actually is there.
Thank you. And just one other quick one. We're just going to have a short afternoon tea, but just one other quick one. Some countries encourage patients to undergo cytology and HPV testing simultaneously. What's the Ministry of Health approach to that.
So in our policy, we do the HPV, triage and treat. So we don't do cytology and HPV co-testing. So this is actually tied with every funding and every resources that we have. So the most effective way in Malaysia is screen, triage and treat.
Thank you. Thanks very much, Dr. Zakiah.